The fetal transition to extrauterine life is a complicated process with numerous opportunities for challenges. The fetus depends on multiple physiologic changes as it transitions to the new environment. These changes include independent breathing accompanied with the transitions from fetal to neonatal circulation, the adaptation of glucose metabolism required for thermoregulation, and fluid balance. Labor, or parturition, is the process where the fetus and placenta are expelled from the uterus. Successful labor depends on three major factors. Those being maternal effort and uterine contractions, fetal characteristics, and pelvic anatomy. The full process of delivery can take anywhere from 12 to 18 hours for first-time mothers, and 6 to 9 hours for subsequent pregnancies. However, these times can vary greatly. Human labor is divided into 3 stages. A contraction describes when the muscles of the uterus tighten then relax. The primary function of the contraction is to expel the fetus from the uterine cavity. The contractions have numerous important effects on the fetus. Each contraction interferes with the flow of oxygenated blood to the placenta. The fetal circulation should not be affected by the contraction unless there are abnormalities of the umbilical cord are present. The first stage of labor can be subdivided into 2 stages, those being the early, or latent stage and active stage. The early stage lasts around 20 hours, or until the cervix dilates to 6 centimeters. During this stage, contractions occur every 5 to 30 minutes and last about 30 seconds. The contractions cause the cervix to dilate to about 3 centimeters and to efface to about 30%. Then, regular contractions will begin every 3 to 5 minutes and last 1 minute or more. This further dilates the cervix to 6 centimeters and leads to about 80% effacement. This begins the active stage of labor, where the cervix is dilated to about 10 centimeters and fully effaces. Contractions become extremely intense and last 1 to 1.5 minutes, with 30 seconds to 2 minutes between. If the amniotic sac remained intact to this point, it should rupture. In the second stage of labor, the cervix is fully dilated and effaced. During this stage, the mother will begin to push the baby out. The pushing depends on the factors of power, passenger, and passage. Power relates to the force of uterine contractions. Passenger relates to the fetus. And passage relates to the route the fetus travels. The most critical element of the passenger is the size of the fetal head. Humans have evolved to have an unfused skull so the brain can develop as much as possible and still safely pass through the mother's pelvis. The normal position is where the fetus's chin is on the chest and the head is at the pelvic inlet. This creates the smallest body diameter as possible. The ideal position is head first with flexion of the head. If the fetus is not in this position, it can create numerous complications for delivery. For example, if the head is facing up and the bottom of the fetus is at the pelvic inlet, called breech position, this can make extraction difficult. When the baby exits the mother, it marks the end of the second stage of labor. During the third stage of labor, the placenta separates from the uterine wall and is delivered. There should be no fragments of the placenta remaining in the uterus. Next, the mother's body makes adaptations to the delivery and blood loss, and the uterus begins to involute or return to normal size. Normal fetal circulation is described as being in 2 parallel circuits, or just parallel circulation, whereas newborn or adult circulation is considered a series. In a series circuit, the current or blood only has one path to follow. The left heart pumps blood to the body and the venous system returns it to the right heart, where it is pumped to the lungs and back to the left heart. In the parallel circuit, the current or blood has different paths it can follow. Because of the fetal shunts and the placenta, blood does not follow a series circulation pattern. Instead, there are two ventricles pumping in parallel to perfuse one systemic circulation because of the three fetal shunts. It's much like a river being divided up into smaller streams, but all the streams return to the same point to form a river again. The majority of cardiac output from the right ventricle is to the placenta and lower half of the body. The majority of cardiac output from the left ventricle is to the heart, brain, and upper body. The ventricles then work unequally, but together to contribute to cardiac output. When blood returns to the heart, about 65% goes to the right ventricle while about 35% goes to the left ventricle. Both ventricles provide systemic blood flow where about 45% is directed to the placenta, but only 8 to 15% goes to pulmonary circulation. After birth, the shunts close, forcing the blood to now travel in a series pattern. Before birth, the fetal lungs are full of fetal lung fluid and the fetus is in a slightly hypoxic state. As oxygenated blood travels from the low-pressure placenta, it mixes with fetal deoxygenated blood. This slightly hypoxic environment maintains the patency of the ductus arteriosus and slightly constricts the pulmonary artery. The placenta also releases prostaglandins that keep the ductus arteriosus open. As the fetus approaches term gestation, it undergoes a few changes to prepare for breathing, circulation, and thermoregulation. Cortisol secretion slowly increases from 30 weeks gestation until delivery, where there is a surge of cortisol. The production of fetal lung fluid gradually decreases as term gestation approaches. As soon as the infant is delivered and detached from the placenta, it assumes responsibility for thermoregulation, metabolic homeostasis, and gas exchange. This is accomplished by closing the fetal shunts, removing the fetal lung fluid from the lungs and replacing it with air, and increasing metabolism to generate heat. Before the infant can begin breathing, fetal lung fluid needs to be removed from the lungs. There are two major factors that influence the removal of fetal lung fluid: vaginal squeeze and reabsorption. As the infant passes through the birth canal, vaginal squeeze will compress the infant's head and thorax. When the thorax is squeezed, about 1/3 of fetal lung fluid is pushed out of the lungs. This also generates a very small amount of elastic recoil of the chest wall, which generates some negative intrathoracic pressure and pulls some air into the lungs. At birth, the infant is exposed to a great deal of physical stimulus and continuous respirations begin. The first breath is usually a short inhalation followed by a prolonged expiratory phase. The inspiration phase of the breath contracts the diaphragm and generates negative pressure to overcome the surface tension in the alveoli so they can be inflated. The expiratory phase of the breath may begin with a short pause as the infant's breath pushes against a closed glottis. This pause will generate high amounts of negative pressure that will continue to force fetal lung fluid out of the alveoli and establish the functional residual capacity. The sodium channels in the lung epithelium are stimulated to open, which helps pull the other 2/3 of fetal lung fluid into the interstitial space. The infant may experience mild hypoxia and hypercapnia immediately after birth, which further stimulates the respiratory center. As the infant continues to breath, the functional residual capacity increases and then maintained at an adequate level. Breathing atmospheric level of oxygen will increase the partial pressure of oxygen in the infant's blood, which causes significant hemodynamic changes. As previously mentioned, fetal circulation relies on three shunts: the ductus arteriosus, ductus venosus, and foramen ovale. Once the infant begins to breath, the fetal shunts need to close, which allows for increased pulmonary blood flow and adequate gas exchange. Closing of the shunts is influenced by a variety of factors. As the umbilical cord is cut, the blood flow through the ductus venosus stops. This causes the vessel to narrow and become non-functional. The foramen ovale is a small flap-like opening between the left and right atrium. In fetal circulation, it shunts blood from the right to left atrium, and patency is maintained by pressure holding the flap open. After the umbilical cord is cut and systemic vascular resistance increases, systemic blood pressure and the pressure in left atrium increases. This closes the foramen oval, much like slamming a door closed. After the pressure in the left atrium increases and shuts the door between them. Because it is flap-like, blood from the right atrium can no longer enter and the foramen ovale is functionally closed. In fetal circulation, patency of the ductus arteriosus is maintained by the lower partial pressures of oxygen in fetal blood, and prostaglandins secreted by the placenta. Once the umbilical cord is cut, it causes an increase in systemic vascular resistance. This causes an increase in pressure backwards through the circulatory system. So, the ductus arteriosus now experiences resistance to flow and the pressure in the left atrium is increased. Removing the umbilical cord also stops the infant from receiving prostaglandins from the placenta. After delivery, initial breathing will aerate the lungs and increase the partial pressure of oxygen in the blood. The pulmonary vascular resistance decreases, allowing more blood flow to the lungs. The fall in pulmonary vascular resistance and increase in systemic vascular resistance causes a massive decrease in blood across the ductus arteriosus. Cortisol is the major regulatory hormone for maturating the fetus as it approaches term and after birth. At about 30 weeks gestation, cortisol secretion is fairly low, but progressively increases until the fetus reaches term. At delivery, there is a surge in cortisol for several hours to facilitate adaptations. Cortisol plays a significant role in preparing the fetus for delivery. As cortisol increases later in gestation, it stimulates surfactant production in the lungs and increases the density of beta receptors on the heart and lungs. It also regulates catecholamine release, matures the thyroid axis, and gut function. Cortisol also works with increasing thyroid hormones to activate the sodium pump in the lungs to facilitate the absorption of fetal lung fluid. Catecholamines, like norepinephrine, epinephrine, and dopamine, are released at delivery due to the infant's stress response. The presence of the catecholamines after birth help increase the infant's blood pressure and mobilize glucose and fatty acids for thermogenesis. After birth, the newborn's ability to maintain temperature control is determined both by environmental factors and internal physiological processes. To maintain blood glucose after separation from the placental circulation, the newborn experiences a surge in catecholamine and glucagon levels and a decrease in insulin amounts. Gluconeogenesis and glycogenolysis in the liver ensures stable blood glucose until oral intake volumes improve over the first few days after birth. Ketone bodies and lactate provide additional energy for the brain, with hepatic ketogenesis increasing after the first 12 hours of age. As with pulmonary changes, many hormonal changes necessary for successful transition to extrauterine life are initiated during the fetal period. Cortisol levels begin to rise at 30 weeks gestation and peak just following delivery. The combined action of cortisol and thyroid hormone activates sodium channel activity that drives resorption of lung fluid. Nephrogenesis is completed by the 34th to 35th week gestation, but the kidneys continue to mature during the fetal period. The glomeruli and nephrons are immature at birth, resulting in a reduced glomerular filtration rate and limited concentrating ability. Lack of renal medulla osmotic gradient and absence of medullary tubules limit urinary concentrating ability. The GFR is further reduced as gestational age decreases. A limited ability to concentrate urine and the reduced GFR make the neonate susceptible to both dehydration and fluid overload. Postnatal maturation of glomerular structure consists of an increase of glomerular membrane permeability, filtration surface area, corpuscular glomerular diameter, and intrarenal redistribution of blood flow. After the umbilical cord is cut, cardiac output to the kidney increased from 3 to 5% to about 8 to 10% by the end of the first week of life and continues to increase during the first month of life. After birth, there is an increase in glomerular filtration and a decrease in renal vascular resistance in response to an increase in mean arterial blood pressure. The increase in renal blood flow and decrease in renal vascular resistance causes higher renal perfusion pressures and an increased glomerular filtration rate. Renal vascular resistance gradually decreases due to the influence of angiotensin II, catecholamines, prostaglandins, and nitric oxide. Renal vascular resistance is highly influenced by the renin-angiotensin system. At birth, water constitutes about 80% of total body weight. Soon after birth, redistribution of body fluids occurs, with early postnatal weight loss corresponding to the isotonic contraction of extracellular water through disposal of excess sodium and water via the kidneys. This postnatal diuresis results in a decrease in 5 to 10% of body weight. The ability to maintain a negative water and sodium balance through a high sodium excretion is inversely proportional to the infant's maturity. As a result, this process results in a greater loss and lasts longer in premature infants. At birth, extracellular fluid is about 44% of total body weight, which subsequently decreases to 30% in the first 6 months of life and then to 20% by adolescence. Extracellular fluid is composed of interstitial fluid and intravascular fluid. However, the majority of excess proportion of extracellular fluid in the neonates is due to higher interstitial fluids. This becomes relevant as neonates have difficulty mobilizing excess fluids and electrolytes, which may clinically result in pulmonary or peripheral edema. The fetal liver is the main site of fetal erythropoiesis and hematopoiesis, with some also occurring in the spleen, before the bone marrow becomes the primary site. Normally the hemoglobin and hematocrit values rise in the first several hours after birth because of the movement of plasma from the intravascular to the extravascular space. Fetal hemoglobin accounts for 70 to 90% of all hemoglobin in the infant. The fetal hemoglobin remains present until about 3 to 6 months of age as it is replaced with adult hemoglobin. Because the infant transitions from a slightly hypoxic environment before birth to a more oxygen-rich environment after birth, erythropoiesis decreases dramatically. This leads to a hemoglobin nadir, or the lowest point, sometime during the first 2 months. This is also known as physiological anemia of the newborn. Once the nadir is reached, it stimulates erythropoiesis to increase hemoglobin levels. Neonates, especially those born preterm, are at high risk of bleeding. They are prone to vitamin K deficiency due to the limited stores at birth and insufficient intake. Coagulation factors do not cross the placental barrier but are synthesized independently by the fetus. This includes vitamin K, which is essential for clotting. At birth, neonates only have 30 to 60% the amount of blood clotting factors that adults have. The intestinal bacteria are critical in synthesizing several vitamins, especially vitamin K. After birth, the newborn infant's intestinal tract is relatively sterile and takes some time to colonize with bacteria. The infant's main source of vitamin K is breast milk until the gut is colonized with bacterial flora, which eventually takes over synthesizing vitamin K. It usually takes 4 to 6 months until the normal intestinal bacteria start making vitamin K. Vitamin K is administered in the delivery room to prevent hemorrhagic disease of the newborn. In utero, the fetus swallows amniotic fluid and it passes through the gastrointestinal system, priming it for use. By 36 to 38 weeks, the gastrointestinal system is mature enough to support extrauterine life. At birth, the infant's stomach can hold about 50 to 60 milliliters. There is active peristalsis, and the infant should pass meconium 24 to 48 hours after birth. The infant's carbohydrate reserves are low at birth and mostly in the form of glycogen. If these stores are depleted, the infant will resort to the metabolism of brown fat for energy. The infant can be breastfed immediately after birth. However, the infant is prone to swallowing air during feeding and crying, so it should be burped. After feeding, the infant's GI tract is no longer sterile and the gastric contents become more acidic. However, the infant is unable to manufacture vitamin K until intestinal flora is established. The infant will digest fats less efficiently because of inadequate amounts of pancreatic enzymes, specifically lipase. The infant will also be deficient in amylase, making it difficult to digest starches and complex carbohydrates. The fat in milk contains lipase and medium-chain triglycerides, making it easier to digest. The autonomic nervous system centers in the brainstem play a critical role in the cardiovascular and respiratory adaptations required for successful fetal neonatal transition. At birth, the autonomic nervous system centers in the brainstem, both sympathetic and parasympathetic divisions, exert coordinated control over the infant's cardiovascular and respiratory systems. These neural systems are supported by major endocrine changes, including a powerful surge of catecholamine levels at birth, which provides more sustained support to the sympathetic nervous system. Together, these processes enable both brisk and sustained responses by which the cardiovascular system adapts to postnatal life. The fetus is born with basic reflexes intact. This include grasp, suck, swallow, Moro's, and tonic neck reflexes. The infant's motor movements are uncoordinated. The sensory perceptions are developed, and the infant can feel pain, hear, smell, taste, and touch. Maternal conditions can significantly affect a newborn's ability to transition effectively. Numerous chronic conditions and infections may impair the fetus's ability to successfully transition. Prenatal testing and screening can help identify factors before delivery. This includes chronic hypertensive disorders or diabetes, substance abuse, lupus, and myasthenia gravis. Acute maternal conditions also cause difficulties in transitions. This includes acute hypertensive disorders like HELLP syndrome, trauma, or acute blood loss. Several fetal conditions can impair successful transition. Some of the most common problems are persistent pulmonary hypertension of the newborn, congenital anomalies, sepsis, pulmonary hypoplasia, prematurity, and small or large for gestational age. Numerous complications can arise during the delivery that can affect successful transition. Providers should avoid elective deliveries before 39 weeks gestation because the fetus undergoes numerous important changes during the third trimester. Cesarean section deliveries should be limited to pregnancies with valid complications. Infants delivered by C-sections have twice as likely to develop respiratory distress syndrome and transient tachypnea compared to vaginal births. Maternal administration of magnesium can impair the infant's ability to successfully transition ion. Other problems include complex presentations, instrumentation-assisted deliveries, maternal analgesia administration, and meconium-stained fluid. Historically, clamping of an umbilical cord occurred within a few seconds after birth. However, current evidence indicates that delaying cord clamping for 30 to 60 seconds after birth is advantageous to the newborn. In term infants, delayed umbilical cord clamping increases hemoglobin levels at birth and improves iron stores in the first several months of life, which may have a favorable effect on developmental outcomes. Delayed umbilical cord clamping is associated with significant neonatal benefits in preterm infants, including improved transitional circulation, better establishment of red blood cell volume, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. Premature infants benefit from a more gradual transition, increased red cell volume and increased circulating blood volume, and decreased risk for intraventricular hemorrhage and necrotizing enterocolitis. A more gradual transition may be the result of allowing neonates to breathe and establish pulmonary blood flow before the cord is clamped. Rapid cord clamping can result in acute increases in systemic vascular resistance and arterial blood pressures, which disrupt pressure-passive organs, most notably in the brain. Delaying cord clamping may result in less fluctuation in blood pressure and cardiac output. The timing of cord clamping is important to the initiation of lung ventilation, and that initiation of ventilation before cord clamping decreases pulmonary vascular resistance and increases pulmonary blood flow. Both avoid rapid increases in impedance and blood pressure seen during routine clamping. The first period of reactivity occurs in the first 30 to 60 minutes after birth, where the infant is alert and exploring. The infant will have a strong suck and attempt to breastfeed. There may be tachycardia, tachypnea, and mild respiratory distress, with periodic breathing and acrocyanosis. The bowel sounds may be inaudible until peristalsis is established, but the infant may pass stool. The period of inactivity is a sleep period and occurs 2 to 3 hours after birth, when the infant essentially loses interest in external stimuli and falls asleep for a few minutes to hours. The infant may be difficult to arouse and be difficult to feed. The heart rate and respiratory rate will stabilize into the normal range, and respiratory effort should fall to baseline. The second period of reactivity occurs around 4 to 6 hours after birth and will last for 10 minutes to several hours. The infant becomes more aroused and shows brief episodes of tachycardia and tachypnea. Bowel sounds may become audible in this period. Most infant pass meconium in this stage. There is also an increase in oral secretions causing gagging or emesis.